Hello, my name is Jessica Wilson, and I am going to be completing a head-to-toe assessment on my patient. Throughout the exam, I am going to have to touch you. Is that okay?
Yes.
Throughout the exam, I'm going to start by looking at her skin. I'm looking at the color, the temperature, the turgor, the texture, the moisture. I'm looking for any signs of edema, scars, bruises, lesions, or nevi. I'm going to begin looking at the head, making sure that it's normocephalic, symmetric, and midline. I'm going to inspect and palpate her head, looking at the hair distribution, the color, and the texture, feeling for any infestations, depressions, lesions, indentations. And then I am going to move forward and begin, I'm going to palpate her temporal arteries, feeling for any tenderness. And then move forward with palpating the lymph nodes. So I've got the pre-auricular, the post-auricular, the occipital, the tonsillar, the submandibular, submental, anterior cervical, posterior cervical, and the supraclavicular. I'm going to come from here and palpate her TMJ. If you will open and close your mouth and move it side to side, feeling for any subluxation, crepitus, or tenderness. And then I'm going to test cranial nerve 5 motor and palpate the masseter muscle, have you clench your jaw. Perfect, it's intact. And then I will test the sensory aspect of this cranial nerve 5. Have you close your eyes and tell me where you feel me touch.
Forehead, nose, cheek, chin, cheek.
Perfect, cranial nerve 5 is intact. And then I'm gonna have you look at me, raise your eyebrows, pucker your lips, puff out your cheeks, smile and frown. Cranial nerve 7 is intact. From here, I'm going to move to the ears, inspecting the ears bilaterally, looking at the sides and position, palpating the pinna and the tragus, feeling for any masses or lesions or tenderness. I'm going to inspect the auditory canal bilaterally. Going to ensure that there's a pearly gray tympanic membrane, and there is. And then again on this side, pearly gray, perfect. I'm then going to assess her hearing. I'm going to have you occlude the ear opposite of me and repeat after me. 1, 2, 3. Okay, and then occlude the ear opposite.
3, 2, 1.
Perfect. And then I'm going to test for lateralization of sound. Tell me if you hear this in one or both ears.
Both.
Perfect. And then that's the Weber test. Then I'm going to perform the Ren test. Tell me when you stop hearing.
Now. Now.
Perfect. Same thing on the opposite side.
Now. Now.
Perfect. Air conduction is greater than bone conduction, and cranial nerve 8 is intact. I'm then going to move on to the eyes, assessing the eyebrows, the eyelashes, and the palpebral fissures. I'm going to look in her eyes, looking at the sclera, the conjunctiva, looking at the color of both, looking for any lesions or discharge, which I see none. I'm going to test cranial nerve 2, checking for gross visual acuity, both centrally, and if you will, cover one eye and tell me the lowest line you can read.
LTFPH.
And opposite.
LTFPH.
Okay, cranial nerve 2 is intact. The patient is 20/20 bilaterally. Also testing for peripheral vision, if you will. Keep looking forward and tell me what number I'm holding up.
3.
Same thing over here.
4.
Perfect. Peripheral vision is intact. I'm going to now move to looking at the eye. I'm going to have you look at my nose and look at the pupils. The pupils are equal, round, and reactive to light, and both directly and consensually. And now testing for accommodation and convergence. If you'll focus on my pen and then look past me at the wall. Perfect. And then look at my pen again and follow it in. Perfect. And then testing extraocular movements. If you'll just follow my finger. Perfect. Cranial nerves 3, 4, and 6 are intact. Lastly, with the eyes, I'm going to look at the internal eye structures, looking for the red reflex, making sure there's no signs of hemorrhage. Optic disc is present and intact, no signs of hemorrhage. Perfect. Okay, then I'm going to move to the patient's nose, looking at it, it's symmetric, midline on the face, checking nasal patency. I'm going to have you occlude one nostril and breathe. Perfect. Opposite nostril the same way. Can you smell and tell me what you smell?
Roses.
Okay. Cranial nerve 1 is intact. I'm then going to palpate your frontal and your maxillary sinuses, feeling for any tenderness, which none is noted. I'm then going to move to your mouth, assessing the lips, open up, the teeth, the buccal mucosa, the salivary ducts, the tongue, under the tongue, the back of the throat, say the tonsils, the uvula, the soft palate, the hard palate. I'm going to have you say The soft palate and the uvula rise with phonation. Cranial nerve 9 and 10 are intact. And then if you'll stick out your tongue for me, the tongue is midline without fasciculations. Cranial nerve 12 is intact. Moving on from the mouth, I'm going to move to her neck and palpate the trachea, ensuring that it's midline, which it is. And then I'm going to have you swallow. Okay, feeling the thyroid gland. There's no signs of nodules or masses there. I'm then going to palpate the carotid arteries, both separately. Both are 2+. And then I'm going to auscultate with the bell of my stethoscope, listening for any bruits. You hold your breath. Okay, breathe and then breathe. Perfect. I'm then going to move forward to the respiratory exam. If you can turn facing opposite of me. Starting with the posterior chest, I'm inspecting, looking for any signs of respiratory distress, use of accessory muscles, tachypnea, nasal flaring, retractions, tripod positioning, which I see none. I'm going to palpate for symmetrical chest expansion. If you can see that, if you'll take a deep breath. Perfect. And then I'm going to perform tactile fremitus if you'll say 99 every time you feel my hands.
99, 99, 99, 99, 99.
And then I'm going to percuss in the intercostal spaces. Ensuring you get the lateral lung fields. And then I'm going to auscultate starting above the scapula, moving in a stair-step manner back and forth, ensuring to listen to both the lateral lung fields and the lower lung fields bilaterally. I'm now going to test for egophony. So if you feel, when you feel my stethoscope, if you will say E,
E, E, E, E.
and I would continue that down through all lung fields. If you're going to test for bronchophony, if you will say 99,
99, 99, 99, 99.
and continue that down. And now testing for whisper pectoriloquy. If you will whisper 1, 2, 3.
1, 2, 3. 1, 2, 3. 1, 2, 3. 1, 2, 3. 1, 2, 3.
And continuing that down, which I hear no abnormalities. I'm going to then move to the anterior chest, so you can turn back around facing the camera. Again, looking for on anterior and posterior any signs of obvious deformities and ensuring symmetry. I'm going to palpate for symmetric chest expansion while she's breathing. Take a deep breath, and it is. And then tactile fremitus.
99, 99, 99, 99, 99.
And then I will auscultate here as well. Again, ensuring to listen in the intercostal spaces. Moving back and forth in a stair-step manner. Getting all lung fields at the bases and both laterally. I'm then going to move to the patient's cardiac exam. I'm going to start by auscultating the heart valves. The first is the aortic. It's second intercostal space, right sternal border. Move to the pulmonic, second intercostal space, left sternal border. Herbs is third intercostal space, left sternal border. The tricuspid is fourth intercostal space, left sternal border, and the mitral is fifth intercostal space, mid-clavicular line. I would also auscultate here to the apical pulse for 1 full minute, noting the rate and rhythm. This is also where I would palpate and feel for the point of maximal intensity. I would then repeat my exam with the bell of my stethoscope at the aortic, pulmonic, herbs, tricuspid, and mitral. I'm then going to have the patient lie down, noting at a 30 to 45 degree angle, looking for any JVD or jugular vein pulsation, which I see none. I'm then going to inspect, looking for any heaves or lifts, which I see none, and then I'm going to palpate over the heart valves, looking for any, feeling for any thrills, which I feel none. So then I'm going to repeat my cardiac auscultation over the valves, first starting with my diaphragm in the aortic, pulmonic, tricuspid, aortic, pulmonic, herbs, tricuspid, and mitral, and then changing to my bell, it's the aortic, pulmonic, herbs, tricuspid, and mitral. Then I will move to the abdominal portion of the exam. Is it okay if I lift your shirt up? Okay, I'm going to begin just by inspecting, looking at the abdominal contour, looking for symmetry, which everything is symmetric. I'm going to begin with auscultation. I'm going to listen to the bowel sounds starting in the right lower quadrant and moving forward. And then I will listen with the bell of my stethoscope, listening for any bruits in the abdominal aortic artery, and then the renal arteries here, and then the iliac arteries here, and then the femoral arteries here, which I hear no abnormalities. I'm then going to percuss, listening for dullness, tympany, or flatness. I'm then going to move to palpate the abdomen, feeling for any masses or tenderness. And then I'm going to attempt to palpate the liver and the spleen, which is, they are both unable to be palpated, which is a normal finding. I'm then going to have you sit forward and kind of face me. And I'm going to come around and palpate or percuss for CVA tenderness. Any?
No.
Perfect. Okay, at this point, we are going to move to the musculoskeletal part of the exam. I'm going to start with your upper extremities. I'm going to start looking in your hands, your wrists, your elbows, and your shoulders. I'm going to be feeling for redness, tenderness, crepitus, deformity, any swelling, nodules, and looking to make sure the joints are symmetric. I'm going to begin by palpating the radial pulses and checking for capillary refill, which are both good. And then I'm going to test the range of motion of your fingers. So if you'll flex, extend, hyperextend, abduct, adduct, and then thumb opposition. And then for your wrist, if you'll flex, extend, hyperextend, radial deviation, ulnar deviation, and rotation. And then for your elbows, if you'll flex, extend, hyperextend, and then we'll move to your shoulder. So you're going to flex forward, extend, hyperextend, internal rotation, external rotation, adduction, abduction, and then circumduction. From here, I am going to check the strength of what we just did with range of motion. So if you'll squeeze my fingers, strength of 5 out of 5. If you'll, with your elbows for your biceps and triceps, pull against my resistance and then push against my resistance, perfect, 5 out of 5. And then push your elbows up, abduct against my resistance, and then adduct, pull in, it's perfect, 5 out of 5. From here, I'm going to check cranial nerve 11. If you'll shrug against my resistance, cranial nerve 11 is intact. From here, we're going to check cerebellar coordination, and if you will, just do serial finger opposition and do the bilateral hand flop. Perfect. And then from this point, put your finger to your nose and follow my finger and then back to your nose repetitively. Perfect. So then we're going to test sterignosis and graphesthesia. I'll drop something. Here it is. If you will, close your eyes and tell me what object you feel in your hand.
Sponge.
Perfect. And then tell me which letter I'm writing in your hand.
C.
Perfect. I'm then going to test, you can open your eyes now. Well, actually close them again. I'm going to test the touch sensation to your upper and lower extremities. Tell me where you feel me touch.
Arm. Arm. Leg.
Leg. Perfect. You can open up again. During this, I'm looking at the skin integrity of the upper and lower extremities, looking at the color and checking for any edema as well. I'm going to check the vibratory sensation of the upper and lower extremities by placing this tuning fork. Tell me if you can feel it over the ulnar prominences.
Yes. Yes.
And then on the medial malleolus.
Yes. Yes.
Okay. From here, I'm going to check deep tendon reflexes, starting with the brachioradialis, moving to the bicep, tricep, moving this way, bicep, tricep, patellar, leaning up doing the Achilles, and the Babinski for both. Sorry, it probably tickles. From here, now that we're down here, I'm going to assess the joints of both the feet, the toes, the ankles, the knees, and the hips. I'm going to assess the dorsalis pedis and the posterior tibial pulses. Both are 2+. I'm going to check for capillary refill bilaterally. Perfect. And then I'm going to go ahead and we will do with my finger, with your toes as I am with my fingers. We're going to check flexion, extension, hyperextension, abduct, adduct. And then with your feet, if you'll plantar flex down and then dorsiflex up, inversion, eversion, and then rotation. I'm going to go ahead and test the strength here. If you'll plantar flex against my resistance, dorsiflex up against my resistance, push your knees out against my resistance, perfect. Pull against my resistance, and then with your push out, or pull in, and then push out. So the strength is 5 out of 5 for the hips, knees, and the ankles. From this point, I'm gonna have you stand up. We're gonna check the range of motion first for your hips, for your knees. So we're gonna flex, extend, hyperextend, flex, extend, hyperextend. For your hips, we're gonna flex, extend, hyperextend, internal rotation, external rotation, adduction, abduction, and circumduction. Same thing with the other one. You're gonna flex, extend, hyperextend, internal rotation, external rotation, adduction, abduction, and circumduction. Perfect, range of motion's intact. So from here, I will kind of have you turn this way. I'm gonna have you flex forward, looking at the spine, looking at the expected curvature, assessing for any signs of scoliosis, redness or tenderness down the spine, which I see none. She is already flexed, so for spinal, we're gonna have flexion if you'll extend up, and then hyperextend back, lateral flexion to both sides, and then rotation. Perfect, and then for your neck, for cervical, we're gonna flex forward, extend, hyperextend back, lateral flexion to both sides, and rotation. Perfect. From here, I'm gonna stand behind you, have your arms down at your side. If you will, close your eyes and just stand still for a moment and check Romberg. Romberg is intact, there's no swaying. And then if you will, walk forward, heel to toe, and then turn back and walk normal to me. Perfect. Gait is intact, both normally and tandem gait. And then if you will, hop on one foot and swap and hop on the other foot. And that concludes our assessment.